OsteoSignal Episode 9. This is OsteoSignal with Neal D. O'Neal, a podcast exploring how your body's natural design connects with osteopathic science. Translating complex signals into practical insights so you can truly thrive.
Okay, pain is a liar. Why non-physician osteopathic manual therapy is the missing piece in modern healthcare. So pain is a liar. Let me say that again. Pain is a liar. Not because people's suffering isn't real, but because pain is an unreliable narrator. It tells you that the problem is where it hurts. It tells you that the solution is a pill. It tells you that your body is broken. But what if I told you that your pain is often pointing to the wrong place? What if treating only the painful area is like patching a smoke detector instead of putting out the fire? So today, we're stepping into a conversation I've wanted to have for a long time. What exactly is a non-physician osteopathic manual therapist? And why is this approach essential for true healthcare, real healthcare, not disease management or sick care? Okay, stick around, because once you understand what this type of osteopathic training actually does, you'll never look at your body, your pain, or your healthcare system the same way again. Okay, so if you're new here, I'm Neal O'Neal, physical therapist, certified osteopathic manual therapist, and osteopathic manual therapist. I've spent the last 25 years learning from and working alongside some of the most unique osteopathic minds: Lauren Rex Dio, Lino Cedros, Marion Pottinger, Frank Chapman, Beryl Arbuckle, Phil Greenman, Paul Kimberly. Some of those people just in books, but they had a lot to say. People who think in systems, not symptoms. And the reason I created this podcast is simple: to bring the forgotten language of the body back into healthcare. Because somewhere along the way, medicine became biochemical only. Diagnose, prescribe, repeat. But the human body isn't a pharmaceutical algorithm. Your symptoms aren't random. Your structure is not passive. Your nervous system is not broken. It's adaptive. So what is a non-physician osteopathic manual therapist? Why don't we start there? So what does that term even mean, non-physician osteopathic manual therapist? Well, here's the simplest definition. A non-physician osteopathic manual therapist is a clinician trained to diagnose and treat dysfunction in the body using hands-on structural, fascial, neurological, embryological, and biomechanical principles without practicing medicine and without relying on drugs or surgery. We work in a different domain: biomechanical signaling, fascial tensegrity, neuroelectrical conduction, visceral mobility and suspension systems, fluid dynamics, lymphatic, venous, cerebrospinal fluid, and obviously arterial, embryologic patterning of tissues and diaphragms, interoceptive physiology, your internal sense of self and what's going on inside of you and how that it manifests itself in your central nervous system. This is the body's silent operating system. It's not taught in standard PT or medical school, and it's not accessible through imaging, labs, or injections. A non-physician osteopathic manual therapist is not there to replace your doctor. They're there to interpret the mechanical and physiological story your body is trying to tell, because your body always tells the truth, but pain often does not.
Awesome.
Okay.
Can we go back and
Sure.
maybe elaborate on some of those terms for
Let's do it.
a listener like me who isn't familiar with tensegrity or...
Yeah. So let's cover some of those things. Well, biomechanical signaling. And so let's start there, because an important concept here is that when there's biomechanical forces that act on your body, whether that's your body doing the acting or other things acting upon your body, let's say that it's fluid and inflammation, that's going to stretch your tissues. And it's what we call mechanotransduction. A lot of your nerves take mechanical information and turn that into neurological, electrical information that it shares with your central nervous system.
Is that due to pressure within the tissue, that because it's inflamed, it expands?
Exactly.
And it puts pressure on those nerves, and then the nerves take that pressure and turns it into electrical signals that get sent to your brain. Is that how that works?
That's a great example. But that could also be a blow to something. So inflammation can do that. Chemicals can do that. Say that you have an irritating chemical. One of the things that happens is that when you break open a cell, there are chemicals that are on the inside, or at least there are things on the inside that then have a reaction out in the tissue, in the extracellular matrix, that inside chemicals will react with the external chemicals that make them inflammatory. And so the part, not only is that edema, right, the stretching part, but also just chemicals that irritate the nerves.
I
So you
see.
get this biomechanical information is then turned into biochemical and bioelectrical information. So you have to know all three of those parts of it and be able to, jump back and forth. Like, what's this information mean? What does that information mean? So you may have some reported problem, but that reported problem is just where there's too much motion, or there's inflammation, or where the chemicals have built up. Well, sometimes because your body is constantly trying to move stuff around, the chemicals may build up in your ankle, even though you've hurt your hip or back or your knee, right? So for one example. So there's a lot of examples when the signal you're getting is the wrong signal. It's a signal, but it doesn't give you any more information than something is wrong. And then, for example, fascial tensegrity. Tensegrity is this idea that you have hard elements and contractile elements like muscles or ligaments or tendons, and they're all connected to each other, so that there's this framework of, as forces move through the system, they transmit and are transferred through hard elements like bones or cartilage, and they're of course also moved around by contractile elements like muscles. But that can also be nerves. Nerves have a contractile element to them. Tendons have a contractile element to them, not as much as the muscle, obviously. But even ligaments can have a contractile, or at least motion limiting presence or force into the system. So that all changes what everybody else or whatever other part of your body senses. Okay, so we have this neuroelectrical, and then that gives you neuroelectrical conduction, right? The nerves conduct electricity through a couple of different means, but we'll just call it bioelectrical flow. Then visceral mobility, how do your organs move? So for example, when people go to bend over to tie their shoes, does your liver or gallbladder move out of the way, or is it too swollen? And then of course there's a capsule around that if you stretch it, it says, ow, stop doing that. So there will be people that can't tie their shoes going, oh, I get too much pain in my abdomen here, along my diaphragm, where the liver and the gallbladder are. So visceral mobility and that suspension system that holds them in place has to work properly. Fluid dynamics, lymphatic, for example, the biggest factor affecting your heart and your heart health and in the condition we call congestive heart failure is when you have fluid sitting in the capillary beds and the lymphatic system of your feet, ankles, and lower extremity, right? Your calves. The heart has to push the blood against that wall of fluid, and it's also trying to suck that wall of fluid out of there, but gravity's acting on you. Biomechanical processes that should work, like your pelvic floor or your hip or your back or your diaphragm, are not helping the process. So then there's an even taller there's a large column of water sitting there. And of course, that's when people blow out valves and veins, or their lymphatic system doesn't work. Okay. Cerebral spinal fluid is the fluid that bathes your brain, and it actually supports and holds up the brain, does cushion it to a degree, but also does cleans away contaminants that the venous system doesn't, because we don't have a lymphatic system in the brain. We have a glymphatic, but it's only active when you're asleep. Well, what about during the day? You're thinking, you're doing lots of things, you're busy, you still need to move fluid out of there. So the cerebral spinal fluid balances any acid or base aspect as the neurons are burning through glucose. So you'll produce stuff that you can't have a chemical. If your pH changes, the neurons won't function right. So that has to be taken into account.
What is the
Embryological
difference?
pattern.
Let me just ask you, what's the difference between lymphatic and glymphatic?
So lymphatic is out in the body where you have lymph nodes. And in the brain, we see that the astrocytes, they're neurons, but they're support neurons. So they're not the neuron that does the thinking. They're a support cell for neurons that they actually flush contaminants and used up stuff in the extracellular matrix around the brain cells out of the system. So they move it out and say, okay, let's dump this out of here. We need to get it away from the neurons. Otherwise, you have advanced aging of the brain, or just aging of the brain. So that would be called glymphatics. That it's the glial cells. That's where the glymph comes from. So glial lymphatics.
Okay.
Where that, I know that's and then embryological patterning of tissues and diaphragms. How do things go together? Where do they come from? What are the fascial planes, or how are those tissues related? For example, the pelvic floor and the pelvic diaphragm actually come from the same source. as does the pericardium. So all those structures have to move together, or none of them help pump fluid appropriately. But the diaphragm comes from C3, 4, and 5. So neck, shoulder, and especially bilateral shoulder, if anything presses on there or irritates the diaphragm, your pain may show up here. But that's because of the embryological origin of the diaphragm. So again, you can see where pain might not tell you the right story. And then what we call interoceptive physiology, your internal sense of self. And that comes in through your limbic system, in through your hypothalamus and thalamus. So then those structures, which are, deep brain structures, midbrain structures, you don't have conscious control over those. So sometimes it's only if that system decides that the sensation is important, does your conscious level mind become aware of it. And then, of course, by now you have all sorts of problems and you can't figure out where it's coming from, because often when that information comes in, it'll come in on a specific set of nerves, your autonomic nerves, but they're not very specific as to area. So what they tend to do is they tend to hand their information over to the somatic body wall cells, who are very specific about where they're from. But the problem being that then you go, oh, I've got this sharp pain in between my shoulder blade on the right. It's more right-sided. Yeah, well, that's where the gallbladder reflects. Or I've got neck and elbow and shoulder and jaw pain. Right, that's the heart and pericardium, really. It's the pericardium that will tell you, oh, this is where my pain is, because it's a derivative of the diaphragm, right? Well, the structure that makes the diaphragm, but whatever. Moving on. So that internal sense of self, right? So you can see all these ways why pain is a liar, that there's lots of information coming in. It's being taken up by your systems in very complex ways, but the system's not built to necessarily tell your conscious level mind, hey, rub right here, that'll be better. It's reporting like, hey, something's irritating you. Whatever you did, like, hey, you know that really hot food you just ate and it really caused you a lot of pain? Don't eat that again. Things like that. Or you ate bad food and you throw it up. But other things as well, like, hey, that iron is hot. You shouldn't touch that. So you get all this information coming in. And, if there's direct trauma, your pain will often be right at the point of the problem. However, over time, think about a direct trauma that you sustained years and years and years ago. When you were a kid, you rolled your ankle and you're not even aware of it at this point because it was so long ago and seems inconsequential. And yet your ankle doesn't function. So you come in to see an osteopathic, non-physician osteopathic manual therapist, and they say, oh, gosh, your back pain is because your ankle doesn't function properly. Say, no, but the pain's up here. Can you just push right here? And of course, the patient's seen umpteen people who have all rubbed right there and taken pictures and put steroids and whatever and haven't gotten the problem to assuage or to fix. That's what makes an osteopathic manual therapist different. We look at this systems analysis of like, how do these systems interact and where do those overlaps come in, such that information might show up here, but it's a derivation of this problem over here, and in going through a proper history, et cetera, et cetera.
It's really what makes us weird, right? Amongst our colleagues.
Exactly.
I have patients, I know you have the same ones where they'll come in and they'll tease you and say, well, I've got a headache, so I'm sure going to wiggle my big toe. You're like, yeah, probably. Or, who knows what, maybe. So it worked last time and, but not all the same, but we're always looking in different places that are not just where it hurts. And that's what makes us strange to patients, especially at first. And they kind of get a kick out of it, I think, after a while.
Right. Well, once they begin to understand that relationship of just because it hurts there doesn't mean that's where we should start. In fact, we're probably going to start as far away from that site as possible, because we're trying to angulate back to work. We want to get all the players in the room. Like if you have an auditorium of people screaming, we're going to start at the back of the auditorium and tell people, okay, no screaming. And then we'll get to the front row and say, no screaming. And then we'll be on the stage and say, okay, look at that. Things feel better. So there you go. All right.
All right. So maybe if you wanted to summarize the approach that a non-physician osteopathic manual therapist takes to alleviating dysfunction, what would what's your 30-second elevator pitch?
Yeah. So it's systems analysis and understanding all those systems, from embryology, physiology, anatomy, pathology. You have to know how it breaks down. If you can integrate those systems, and then knowing systems, system by system, arteriovenous, respiratory, cardiorespiratory, musculoskeletal, neurological, knowing all those systems, how they overlap, where they came from, how they break down, and then understanding those systems, analyzing it and saying, and then doing testing, getting instant feedback from the body of like, what about this? What about this? What about this? What about this? And having that straight approach, right, to be able to ferret out where the problems actually arise.
Awesome. And then earlier, you mentioned that, this type of healthcare doesn't necessarily replace, a person's doctor or other medical professionals. Could you maybe elaborate on how this integrates with, traditional healthcare and how it amplifies or supplements or
Right.
improves outcomes for people, just so that listeners can get an idea of, how or why they would want to integrate osteopathic manual therapy into their lifestyle?
Certainly. So we're not going to replace your doctor. There are certain things that physicians do. They save our lives. They do great. They do great things. The issue is you kind of think of this as the environmental cleanup crew. Like, for example, somebody has cancer. The doctor goes in, cuts out the tumor, and all is better now. But the patient has all sorts of pain and problems left over from the tumor having been there. Or let's say it's not a tumor. Let's just say it's a uterine fibroid or an enlarged prostate. There's still the environmental damage that's been done to the body by having some structure that wasn't supposed to be there, that altered function, that altered stretched out tissue, caused this, caused that, and that the body also had an immune response to over time. And the body tried to heal from or grow from that. The body has grown in a specific way. So a doctor is going to fix a primary problem. Or for example, a total hip. They're going to replace the hip, but did they go back and say, okay, you'll never need another hip replacement because we fixed why you needed a total hip? No, they just say, we've started the clock over for you. You have a good hip for now. So our job
there's
is
a lot of, because there's a lot of maybe prior issues before that kind of intervention, and there's a lot of follow-on, issues to look at afterwards that osteopathic manual therapy can really address and help.
Yeah. I mean, you think about this, particularly surgeries, that there's a lot of trauma done to the body in doing the surgery. But one of the injuries people don't say, let's say that it's a uterine fibroid and you have to have a hysterectomy. How many people understand that you have to go and treat the throat afterwards? Why? The patient was under. That means they put a tube down their throat.
Right?
They were intubated. And that is an injury. That is a surgical injury that has to be mitigated. Otherwise, you affect their ability to swallow, to not snore, to breathe appropriately. So
cool.
you can see how
people, go ahead.
Yeah, so you can see how these things are integrated, that it's like there is the environmental cleanup of all the other things that go around with that, hey, the doc did the primary job, but that doesn't mean that we don't have to then mitigate what it was that happened to the body having that fibroid tumor there or that fibroid there, and also mitigate what it took to get rid of it and how the body is trying to heal. Yeah.
Yeah, and it's not necessarily acute, trauma or an acute medical intervention. A lot of times it's chronic, little stuff that people pick up just with age or lifestyle or, maybe your job. You have a lot of repetitive things that go on that affect the way that you move or, right? What were you going to say?
Oh, no, entirely. Yeah. So go ahead.
Sorry. I was going to say that, like, with my hips or with my hip replacement patients, right? They're like, well, how come one hip wore out and the other one didn't? I took both the hips everywhere I went my whole life. And you're like, yeah, but one of them got really, totally hammered and the other one didn't. And that's what we have, whether we are a primary person to treat something or whether we're, adjunct, it doesn't matter. OMT should always be part of any kind of healing when you have an injury, in my opinion. But the reason that, that hip injured is because something else kept shoving force that way or kept pulling on it or whatever. And so that doesn't get ever operated on when someone gets a hip replacement. So we're trying to go, okay, well, let's make it so I always try and treat patients before they get the hip replacement and say, well, let's get everything as healthy and as even as possible so that when they cut, they're not cutting something that's totally bound down, locked down, glued on, because you have much better outcomes when you have good blood flow and stuff. And let's make sure that the bone can heal after it's been cut into, right? And then afterwards, we got to do where the tourniquet was, where the intubation was, and get the chest moving again and get them so they can sleep hopefully better that first night. I have them come the same day they get out of the hospital and just treat the stuff that's not the incision, right? But yeah, it's just the stuff that led you to that in the first place, and that you hobbled around on a bad hip for a long time, and that was all wrong, and your neck and shoulders and everything else are going to be off from that too, and that has to be fixed. You can't just have a body that's been all compensated for because of that injury, and then put a good hip on it, good hip, right, and then have the whole body be okay. It doesn't work that way. It just doesn't. And any patient that's ever had a hip replacement will tell you, well, I felt like total garbage when I was done. So yeah, there's a lot to
Well,
do.
and then you see that somebody gets a total hip and, immediately, the body has grown a certain direction with that aberrant hip and
Mhm.
and the reasons that it got there. Well, so not only do the reasons that it became, that had a need for a total hip, not only do those need to be addressed, but then the growth process of the body has now deformed, like, for example, like acquired scoliosis and several other things. You have to bring that person back, because there's going to be somewhat like pregnancy, where a woman's posture changes, and then boom, she gives birth, and they spring back. And that springing back, all of a sudden, you're like, wow, you just released all this tension. The problem was, the diving board is still vibrating, and that doesn't feel good to the body. And then who knows where the body's going to get stuck in that? Can it return to normal, or to, as close to normal as possible? Can it do that on its own? Not often, right? There's always things that have to be cleaned up, like you were saying. All those other, the neck, the back, the shoulders, all these other things that go around that also have to be helped along. So as the person's healing, we're kind of like the tender. We tend to the healing, right? And say, okay, we need to help this heal back to where it goes. We help the body do the job it's designed to do, which is restore function. But it can't. It's not like the body tore everything out and rebuilt it, as if you were a fetus again. What it does is it says, here's what I've got. I'm going to clean this up as best as I can. I'm going to kind of try and glue some things together and stick some hard stuff in there. And yeah, okay, I got some tape on there. Perfect. Good enough. None of us wants the taped up body parts. We want the parts that move fluidly again.
And they don't have to settle for taped up body parts either. The body
Right.
can heal much better than allopathic medicine gives us credit for. So,
Well, yeah. They just kind of say, well, there, you're all better, son. What are you
or
complaining about?
better than you were.
Yeah.
Right? At least
And
that
they're not
part that I
wrong.
deal with.
Right. But they're also not trained to see that, to say, how far out of function were you and how far into function? All they care about is the tip, the uterus, the knee, the whatever it is, this 6-inch box around what they're doing. They say, look, my concern's that. And great, that's fine for the physician or for the orthopedic surgeon or whichever surgeon. But for, somebody else has to be there to say, okay, I'm worried about everything else. Somebody took care of that job. My job is to make that fit with everything that was there and actually undo some of the, you don't grow crops in a crappy field. You have to, turn over the dirt. You have to do this. You have to do that. You have to weed it. You have to do all these other things to make the crops grow. So just that, because the surgeon came in and put the seeds in the ground doesn't mean everything was perfect. And that's kind of what we do.
Mm-hmm.
Awesome.
Okay. Yeah. So that's, that's where we go. And that's why, it's our job to understand this systems analysis approach. That's certainly what I teach in my courses. That's what the osteopathic method is understanding systems analysis, systems overlay. And some people get that better than others. But it really is a big point of what we're trying to do. We're trying to not only help our patients understand their own body health, but we're trying to lead their body along that pathway of like, hey, let's get you back to function and understanding here, there, and then how sometimes there are disparate injuries that they come together and form a complex of dysfunction that ends up causing all sorts of problems.
Yep.
Yeah. So, and that's where, pain is often referred, right? Knee pain can come from the hip, shoulder pain can come from the diaphragm. Pain exaggerates the threat. Your brain always errs on the side of survival. So it always says, hey, this is horrible. This is terrible. I think this shoulder is going to kill me. I better operate on it right now. Because of course we go for the big fix. Like, I want this fixed. I don't want half measures. The problem is too much fix has a lot of damage with it. Recovering from rotator cuff surgery is about a year minimum, if ever, and there's the whole problem. So if we can avoid those things, and there's also, part of it is our perspective, our viewpoint of being able to explain to patients, like, well, what is regenerative medical care and what is degenerative? For example, corticosteroids and surgery are degenerative. We're just going to tear that out and start over, as opposed to regenerative of, maybe PRP, maybe peptides, maybe there's a supplement or something that you should look at this information. Talk to your doctor about that. And how do we help lead people to health as opposed to just dealing with the sick part or the broken part. We deal with the health around that. Okay, and the other problem with pain is it focuses people on the symptoms, not the source. Like everybody knows that you had a really bad cold, you go into the doctor, they give you medication, and the medications are always for every symptom you have. None of them are for the virus that you have. Now, every once in a while, you have somebody saying, "Oh, my naturopath told me to take zinc." At least there's an approach to saying, "Hey, we're going to do something to the virus." Or lysine. Lysine's a great way to knock out viruses. But I had a patient years ago who'd come to me and she goes, "Look, I'm having some weird symptoms and they keep coming and going and coming and going and no one's been able to help me. I've been to the doctor several times. I was hoping you could ferret this out for me." And she says, "Well, it's like I have the flu for 3 days and then it goes away for a week. And then I have it for 3 days." And I'm thinking, yeah, look, non-physician osteopathic manual therapist here. No, you're in the wrong office. And she goes, no, I've asked the docs. Nobody can help me. And the whole process was taking her through what she'd been doing and why. And then, of course, as it comes out, she had gotten West Nile virus. Of course, in Washington State, the doctors say, "Oh, you can't have West Nile virus in Washington. We don't have it here." Well, all the horse people know that we do because all the horses have it. And then if you go east of the mountains, which she had done, there's lots of West Nile virus over there. It's just the physicians on the west side of the mountains didn't think that anybody ever went over there for some strange reason. So when I said, "Well,
nobody travels,"
nobody travels, right? So, and I asked her, I was like, "Well, why don't you do this test?" She goes, "Okay, I'm going to go do the test." And the doc went and did the test. And I says, "Okay, great." She came back and she goes, "Okay, that was awesome." I'm like, "Okay, now we know what it was." I said, "So which antivirals did they give you?"
That's the kicker.
They didn't give her anything. I was like,
Nope.
Okay. And I'm not that I'm, I don't prescribe, but that there are antivirals, and then why certain viruses, unfortunately, sometimes things are treated either because the establishment has figured out there's big money in that, or it's a political thing where people, "Oh my gosh, we got to scare you with this virus, but this other one that's really going to cause you to be sterile, we don't care." Anyway, so people are coming from South America all the time, and they've been exposed to Zika virus, and they might have testicular pain, and unfortunately, that can mean that they may not be able to have kids. Right, the whole Zika virus thing really screws stuff up. So and nobody's even looking. For whatever reason, the importance of that sort of thing has fallen off. I don't know why. So, but it's also leading people to say that, tell people these sort of things and say, "Hey, we need to look at that." Anyway. Okay, so again, pain is the language of the mechanical system. And if you're not trained in the mechanics, the embryology, the fascia, and the subtle motion, then all you can do is manage the symptoms. And symptom management is great as long as it's just an acute flare-up. But if it's going to be ongoing or episodic or regular, let's get to the source.
Is that kind of like putting a topical anesthetic on
wherever it hurts?
On something, yeah.
Yeah, no, totally. If people go, "Well, it makes difference for 2 hours."
Yeah.
But it comes back every day or every 2 hours.
Yeah, like putting icy hot on sore muscles or something like that. I mean,
exactly.
It helps, but in the long run, yeah, you want to find the source.
If it was just that workout that you did, great. But if it happens to be that you actually have some, and we all have aging body parts at some point, parts that have been injured in the past. If we don't go and make your elbow move appropriately, you're going to continue to have muscle pain. Oh gosh, why is my arm hurt? Okay, so traditional medicine is brilliant at infection, trauma, emergencies, pathology, pharmaceuticals, and surgery, but it was never designed to address chronic pain, mechanical strain, dysregulated physiology, fascial compression, nervous system stacking, which is where the nervous system starts kind of getting a pain cycle going.
Like a feedback loop, kind of?
It's a feedback loop that needs to be broken, and they're not necessarily good at that. Postural load failures, right? Postural adaptation. That's what we definitely specialize in, is looking at people and saying, you've kind of, instead of being straight, you've collapsed in specific areas, and we want to know why. Trauma to the biomechanical matrix, subclinical inflammation. There's a big one. Energy and electrical signaling.
Yeah, what is
subclinical? Subclinical inflammation is, people have slightly swollen ankle. Like, yeah, my ankle's always swollen like that. Okay, well, that tells us that you're not functioning in that area. You're not able to draw fluid out of or drive fluid out of that area. That's a problem. Pelvic floor congestion, congestion on the back of the sacrum and the low back there, or even on the shoulder, or particularly the knee. A lot of people have just chronic swollen knee on one side. And they're going, "I don't know, it's always been swollen like that." And that chronic inflammation It's subclinical because you're not going to the clinic to the doctor to say, hey, do something about this. Or even if you did, they'd kind of go, well, we did an x-ray. Yeah, 6 weeks of physical therapy. Oh, then we did an MRI. We don't see anything. Yeah, just live with it.
Okay.
Yeah, so they're kind of like, yeah.
What else was there?
So then energy and electrical signaling. And, I kind of use the term energy more in people like how much energy do they have to live their life? How excited about things? So mental energy and the electrical signaling, all those neurons and the entire body is using electricity to help drive. For example, hormones and peptides are drawn to areas because there's electrical signaling saying, hey, go to this place. Hey, go to that place. For example, human growth hormone is drawn to an area. This is one of the reasons that really the stem cell thing has not, there's plenty of people going, hey, it worked for me. Yeah, well, Western medicine, we can't tell you why a stem cell worked or a stem cell therapy in one patient works and the next patient doesn't work. But it's because they don't understand the signaling, the electrical signaling. If the area that you're trying to get to heal isn't giving out the right signal, you can't send in troops to go heal it. They don't know where to go, and when they get there, they don't know what to do. And that's the whole thing. Again, back to us making sure that the fascial system, how electricity does flow or doesn't flow. There are certain parts of your body that the electrical flow is not supposed to go there. And so what happens if you have an area that develops charge, your muscles moving all the time, your arteries flowing with hemoglobin through them, that's iron, it creates an electrical flow. So that if that electricity seeps out of that area into an area it's not supposed to be, it actually causes scarring at the interface. So if somebody comes in and they have a keloid scar, that's how you get keloid scarring, is that there's an electrical, there's supposed to be a difference. The electricity is supposed to be held in a compartment. That's why all your groups of muscles, like your flexors or your extensors, are in different fascial coverings so that the information from one group doesn't bleed into the other one, and then you just get tetanus. You'd be like those goats who go to run and then they just fall down on their back, and that's one of the problems. So we have to make sure that's not happening, because guess what causes a lot of pain and a lot of dysfunction is getting charge in the wrong places, and just understanding that concept of, look, humans operate on bioelectricity, biochemistry, and biomechanical forces. All those things change and morph into the other ones as you're going through and around the human body. And if you have a therapist who's been properly trained to understand this, they're looking for those three things and where they might break down, or where the ability to move between them breaks down. And that's what we call dysfunction, right? And so we might be able to put a total hip in there, but now you've put metal in there, and that's going to carry electricity that maybe the previous hip didn't carry, or didn't carry it in all directions. It only carried it in a very specific pattern, which is why we know how to grow bone. The bone knows which way to grow because of the electrical patterning. What if you put a total hip in there? Well, you've just sent electrical flow everywhere, because the metal is going to let it go wherever. Needles, when you put needles in people,
and there's no nerve endings in that new part.
Right, exactly. There's no nerve there to kind of say, hey, that's not what's going on here. Yeah. So so good and bad, medical intervention changes body parts, but there has to be somebody who understands the system and does a systems analysis to say, okay, where are the nexuses of dysfunction, the nexuses of where things break down, and those may be far away from where the pain is, or even where you see wear and tear and like arthritis or this, that, the other. Like, why are we getting arthritis in this point? Well, for example, a lot of arthritis in the AC joint here, right? And people get acromioplasties when the real dysfunction is at the other end of the clavicle, that the joint here, where there's an actual disc, and your first rib and C7, T1 affected, that if that dysfunction is here, you'll see the arthritis there. But these surgeries are all here, and none of them are here. And I'm not saying you do surgery to here, but what I'm saying is you do some intervention there to the sternoclavicular joint, right? Okay, so and that's where the osteopathic manual therapy really shines. We access the body's three signals of health: biomechanical, biochemical, bioelectrical, and we help the body be able to switch back and forth between those so that it can control the environment and have health, control the environment and heal. And unlike pharmaceuticals, our feedback is pretty instantaneous. It may take the body a while to do that, but as we're doing our testing, we see a test where two bones are not in a line, and then they go back to being able to be in a line, and then move out of that appropriately. Okay, so tissue softens, breath patterns change, electrical flow shifts, autonomic tone rebalances, pain decreases, often within seconds. not because of magic, but because we restored the body's original design, saying, here's how it's supposed to be able to work. And we remove those barriers to it working that way to allow it to do, and then it can self-profit, it can take care of itself at that point.
So one of the questions I get from my patients a lot is, why don't doctors do this? Like, why at the beginning of our podcast today, we have to say we are non-physician osteopaths? Like, why aren't the physician osteopaths doing this? What is what happened there? What is that?
Well, I mean, let's give physicians their due, right? Let's give physicians their due. If you've ever had an infection, and in the past, before we had antibiotics, infection could be a death sentence at any moment in life because we didn't have antibiotics. And then once that magic bullet of an antibiotic was discovered and used, it was so demonstrably like amazing that people kind of said, wow, doctors have magic bullets. The problem is they have a few magic bullets, but they don't have a machine gun. They can't get the whole body. And again, they tend to focus their magic bullets on one thing. It's like a sniper magic bullet. It's like, yeah, but pick your spot that it's going to fix. And if you have pain or dysfunction and you take a sniper shot at it, well, you're going to get one thing to work right. You have a total knee now. And when you come in and complain about, hey, this isn't right, I can't bend it, I have inflammation, it still hurts at night, I can't sleep, they're going to say, hey, I took my shot. I gave you my magic bullet. That's it. That's all I got. Go away now.
Yep.
And that's where we say, oh, no, this and this and this have to work. And then here's the relationship. Here's how these things all go together. Okay.
I have a theory about that also. I think just in general, our society tends to specialize in certain things. And I think, I don't know. I think, family physicians or general practitioners have to have a general knowledge of things, but I think they've specialized to some degree. And I think, osteopathic manual therapy is way more general. You have to, like you mentioned before, you have to consider all of these different factors and systems. And I think they're just the drive to specialization in so many different fields, even in medicine, kind of pushed the generalists, the osteopathic physicians to the side. And so the non-osteopathic, manual therapy physicians who do manual therapy kind of took a hold of that and thankfully have used it to great benefit for a lot of people. So that's just my 2 cents about that.
No, but I think that's a great analysis of understanding that with specialization in medicine, everybody's going for the highest, value unit, saying, how can I treat 70 patients in one day?
Right.
That's very difficult. And when people, for example, and also the, when somebody comes to an ER, you have to run through a triage and say, most effective treatment, this is this, boom, we're done. Right. Let's keep them alive. So, and if your focus is to keep people alive or stop, somebody from dying right now, they do fantastic at that. Right. But at some point that triage is like, okay, that's great that you had a triage, but what's behind the triage? Like, okay, we've either done that, we've decided where these people are getting whatever. The specialist, as you said, a very specialized person goes, okay, here's what we do. There's the one big fix. Right. You kept them from dying. Now what do we do? Right. Like, oh, they're just going about their lives. Like, well, now they have all this dysfunction, all these other problems, all this pain. Who's going to take care of that?
It's just not the purview of the physicians anymore. They're doing the.
Yeah. And it takes time and they don't have time. Right.
Yeah.
And there's tons of money to be made with pharmaceuticals going, hey, I can prescribe medication. I can have 120 people come into my office and boom, 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 prescription them out. And hey, my treatment was the prescription. Right. And so high value unit, right? They're just going for that high value unit, and it's there's that analogy. There's a story about 2 kids walking along on a beach where the surf has gone out and there's all these starfish, all these sea stars along the beach. And one of the kids is picking them up and flinging them into the water because they're starting to dry out. And the other kid says, you're not going to make any difference to all these, all these sea stars. He goes, I'm making a difference for this one. And that really is kind of where we're at. Our job is to take in the one person in front of us and say, we're doing this for this person. I may not be able to fix everything. And that's why we're doing this podcast, is to get other people to do this as well. Say, look, I can make a difference with this one. and this one and this one, but I can't do all of them at once. So if more people start to do this and pick this up and understand this thought process, they'll demand it more, and more of the people in healthcare will say, well, we have to provide that kind of care, but it's not even appreciated at this point.
Right. A lot of it doesn't even know that people do this kind of stuff. They think, well, I went to the chiropractor, right. I went to physical therapy, and we did some exercises, and I'm able to walk. I still have pain, or whatever, but there's a lot of that too. So
exactly right, and that what happens is you have healthcare practitioners who are not physicians, or not medical doctors, or not DOs, and they're not doing the one medical thing, the sniper shot, if you will. But everybody bases their information of how they're going to treat the patient based off that diagnosis and that approach. And this approach is saying, I don't care that there was a disc that got blown. If we want to heal that disc, and if we want to get the inflammation out, and if we want to change the nervous system's response to that, we have to change the biomechanics. But because what continues to irritate that disc is poor biomechanics, and then that setup creates poor biochemistry, and that poor biochemistry keeps giving us a bad bioelectrical outcome. And so, everybody wants to do this, like treat the disc or treat the fibroid, and then everybody wants to do their treatment based on that. It's like, no. Now that problem's out of the way, let's see the circle of everything else that's going on. It's kind of like throwing a rock in a pond. It's like, okay, you took care of the central part of the hole in the water, but what about every one of those rings that goes further and further out away from that ring? Who takes care of that? We do.
Yep. And we want more people to help us.
Yes.
And we want to educate patients to demand
classes.
that. Yeah, and people to take classes, patients to demand that, because there's a lot of people not happy with the final outcome. They're saying, wait, this can't be it. I was hoping for you to really help me, and maybe you saved my life. That's great, but now my life is not I don't have the quality, right? So who restores that quality? And in a lot of ways, asking the insurance companies to do that is that they're not interested in that at all. Really, what their job is to only give you back some of what you've paid them when they have to, in order to save your life, and sometimes not even then. So, yes. And that's the problem, is that we have this other part of it where it's political, it's money, it's insurance companies, it's pharmaceutical benefits managers, it's doctors, it's
blood system.
There's a lot of flaws in it, and kind of like what Brent alluded to, is like everybody's becoming a specialist, going for the highest value unit. Somebody has to step back and go, well, wait a second, it can't be all about billions. It's got to be about the time with the patient in front of you and saying, what can I do about this one person? How do I restore them to function? And every treatment will be different. And every treatment for every patient will be different every time, because it's what's called a stochastic situation, that anything that happens, the person going down the street changes the situation in front of you. So they always have to be looked at, measured, and treated. Excuse me.
Awesome.
Okay.
All right. So I think, are we kind of coming up on an
end here? Yeah, we're
on an end here? I was just going to ask you. So what's the, what would you like the listeners to take away from this episode?
Well, if today's episode shifted the way people think about pain, about their body, and about what healthcare should look like, share it with someone who needs this, and then seek out manual therapy, osteopathic manual therapy. And then there's a lot of people out there who say they do manual therapy, and they may not take this systems analysis part. And that's the hardest part. We have our people in our group that we talk about, and that we understand this. We talk about this constantly in our classes, and we say we have a systems approach. But across the country, across the world, you may not necessarily have that. There are groups that are trying to do that in various ways. We like to think that we have a pretty high level of systems analysis and integration. So ask healthcare providers around you, who does this? Who do you know that does this? Do you do this? Do you think this way? And then go and see if they can help you. And don't just rely on the medication, because there's a reason we have an opioid epidemic. And it's because people are trying to rely on physicians to take away pain, when that's pain is a liar. It's really hard to affect it appropriately.
Sure. And if you're out there, you want to take classes, go to pursuitpt.com. That's Neal's website, and you'll see up in the menu a spot for classes. Right?
Perfect. Yes, exactly. Okay. So pursuitpt.com, and come to a class, seek people out. You can always get a hold of us through the website and say, oh, look, I'm looking in this area. We do have some videos on YouTube, various other places where we have information. And we love it when people have questions and are demanding better healthcare. So actual healthcare. Okay, but so just remember, pain is a liar, but your body never lies.
Right.
You're just someone who needs
there
to.
are answers. There are answers.
Yeah, and there are answers. You just need
There's
someone
relief.
who could speak the language. Yeah.
Yep.
Right, and that's
right.
what we do. We speak that language.
Awesome. Well, thank you so much, Neal.
All right.
Great
Thanks for
talking with
teaching,
you.
Neal.
All right. Thanks. We got
All right,
through that
See you
one.
on the
Really
next
quick.
episode.
All right. See you on the next episode.
All right.
Bye.
Thanks for joining us on another episode of OsteoSignal with Neal D. O'Neill. For more information, please visit pursuitpt.com or pursuitperformancetraining.com. Our music was written and performed by Sky Toes. Copyright 2026 by Neal D. O'Neill.